So we know from the case now that surgery proved to be difficult as there was very little density and strength to the bone. And this gives us a hint that there's something wrong with Mrs. White's bone at the microscopic level. Now, as we progress through the unit, we'll talk about the different bones that make up the body, but all bones, regardless of their location, have the same microscopic appearance. So that's why we start here. Let's talk about the bone matrix. The bone matrix can essentially be divided down into two different types, the organic and the inorganic. The organic is in 90% made up of collagen, and the remaining 10% is made up of proteoglycan and glycosaminoglycan. Whereas in the inorganic, it's made up predominantly of calcium and phosphate, although there are a few other trace minerals within there. Now, calcium and phosphate, when they exist in bone, they exist in a crystalline formation, and we call that hydroxyapatite. For all you chemistry buffs out there, and I know there's probably a lot of you, here's the chemical formula for hydroxyapatite. For those of you who are not so au fait with chemistry, that's fine. The calcium and the phosphate makes up your apatite, and your hydroxy is referring to these two hydroxide groups at the end of the formula. Now, your inorganic matrix is kind of like a limestone. So this is a typical limestone block, and it's mainly calcium carbonate, and these are some phosphate crystals. And I know you're probably thinking, Morgan, these are some pretty dodgy materials to start constructing some bone out of, and you're absolutely right. And that's why, in addition to the inorganic matrix, we also have to have the organic matrix. And you can think about our collagen like steel bars. So let's go onto a building site and let's look at a typical building site and how we can produce an analogy from the building site to bone. So you can see up here, these are steel rods. So these are rebar. Now, the rebar are a lot like the organic matrix of bone, the collagen. It can be shaped. It can confer an element of elasticity and flexibility to the structure. However, if you add a large compressive load onto rebar, what will happen? It will bend, just like the collagen fibers. Whereas with the inorganic matrix, and we can see the inorganic matrix here being represented by cement or concrete. Actually, as an aside, I don't entirely know the difference between cement or concrete. I think one must have some kind of aggregate in it, but I'm willing to bet that out of all of you medical anatomy students, there's someone who's probably been a civil engineering student out there or have done some construction as a labourer on the summer break. So if you know the difference between cement and concrete, then please write to me off the medical anatomy unit coordinator doesn't know what he's talking about and he needs to work on his analogies, courtesy of Curtin University, Hayman Road, PO Box HUMB 1004. Anyway, let's continue. So the inorganic matrix is probably a lot like this cement. It's very brittle, but it's very strong. Now, if you loaded up cement or concrete with a large, heavy compressive load, it would take that load because it's strong, but there's always a risk that it would crumble. Now, let's have a look at how mature cortical bone is actually represented in cross-section. You should know by now a few things about bone. So we've taken a cross-section from the diaphysis of bone. We can see into this. This is the medullary cavity. And this is the cortex of the bone. The cortex of the bone can be represented at a cross-section and recognized in a cross-section because it has these structures. These structures are osteons. And osteons have a very characteristic shape. In the center, it has a canal, and this is referred to as the central or the Haversian canal. And inside the central canal, you'll find a couple of capillaries, and you'll usually find a couple of nerves. They can be myelinated or unmyelinated nerves in the center. What you'll also see is that surrounding the central canal, you'll see these plates, these bars of mineralized matrix, and these are in concentric circles, and these are referred to as lamellae. Now, in addition to getting lamellae around the central canal in the osteon system, you'll also see lamellae that are deposited on the outside, on the superficial aspects of the bone cortex, and these are referred to as circumferential lamellae. Now, in addition to this, you can see some other typical bone features. One is the periosteum, and this is a fibrocollagenous layer which is continuous with the deep fascia of the body. And this is wrapping around the bone, and the name peri, meaning around, and osteo, indicating bone, should indicate that this is its structure. Now, it's densely innervated and densely vascularized, and it's very sensitive to injury. Now, on the internal surface, lining the medullary cavity, and also lining all of the trabeculae and lining the inside of the Haversian canals, are this, and this is endosteum. Now, the periosteum and the endosteum have a few tricks up their sleeve. See, there's 3 different types of cells that are actually resident within both of these connective tissue layers. You've got the osteoclasts, osteoblasts, and also the osteoprogenitor cells. Now, an additional and the second last feature I want to point out is that attaching the periosteum to the circumferential lamellae here are these Sharpey's fibers. And these are really strong collagen fibers that are going to anchor the periosteum to the outside of the bone. Other features we can see here are these long Haversian canals. So you can see that we've actually cut this bone and you can see the full extent of the canal. And you can identify the canal because it's running parallel to the long axis of the bone. We also have additional canals. Here we have a perforating or a Volkmann's canal, and this is running perpendicular to the long axis of bone. Regardless of whether we're talking about the Haversian or the Volkmann's canals, their purpose is to carry the neurovascular structures of bone. Take note of this spongy or trabecular bone in the medullary cavity because we're going to be looking at that as well in a second. Let's look at a histological representation of the osteon. So here's the full extent of the osteon. And in the center is a central canal. And here is actually an osteocyte. And you'll remember that the osteo prefix is referring to bone and the cyte suffix is referring to a cell. So these are bone cells. And this is where they would normally be residing. And they're sitting in lacunae. And a lacuna in Latin is a cavity or a space. So this is the space that the osteocytes are residing in. And you can see this space outlined faintly in blue in the image. And the area where the cells would reside in life are outlined in red. So you can see a few of these here. So these are the osteocytes in lacunae. Now the L's that are being shown up here are representing the layers of lamellae that are surrounding the central canal. Here's the osteon system again. Here's the central canal. And in life would have, as we said, a few myelinated and unmyelinated nerves in there and a couple of capillaries in there as well. Now what you'll notice is that indicated in red here are these small channels. And these channels are referred to as canaliculi, which are really just small canals. And you can see that they're extending from one osteocyte to another. And this is important. You see, the lamellae are so thick that it's impossible for diffusion to take place between adjacent layers of lamellae unless there's additional canals that have been put in place. And that's exactly what canaliculi represent. So canaliculi functions as little channels for two things to occur. One is for the exchange of nutrients, so our gases and our waste products and nutrients to go through between adjacent osteocytes and adjacent lamellae layers. And the other function of the canaliculi is they actually house little dendritic processes from the osteocytes. And these dendritic processes are important for electrical communication between adjacent osteocytes. Let's now look at trabecular or spongy bone. If we were to zoom up on this trabecular bone, this is what we would see. So what we can see here is actually a single trabecula. And you can see all these little lacunae here where the osteocytes would normally reside in. We're going to digress a little bit from the histology just to look at a plain film radiograph for a second, because I want you to appreciate that trabeculae follow lines of stress. So if we zoom up here in this femoral neck, we can see all these little anastomosing spicules of bone. And those are aligned in a very deliberate fashion. You see that trabeculae will follow Wolff's law, so they'll actually align in a position that is advantageous to absorb the forces that are imposed on bone. It's not particularly interesting to look at, I do appreciate that, but if you lose these trabeculae, you're far more likely to have a fracture of bone. Let's go back to the histology of bone. So let's look at this trabecula, and you can see very clearly that there are no typical osteon formations that we would see in the cortex of bone. Instead, these are just a lattice of bars and rods of lamellae that are surrounded here by bone marrow. And we've got a couple of different types of bone marrow. Here's an example of what our red bone marrow would look like. And in the red bone marrow, we have lots of things, but I only need you at the moment to know 3 of them. We have lots of hematopoietic cells. So they are going to be the cells that produce our red blood cells, our white blood cells, and also our platelets. Now over here is an example of what you might see as being yellow bone marrow. And yellow bone marrow is a fatty kind of bone marrow, and it's a bone marrow that we see predominantly in our bones as we age. Now, there's a couple of different things in there, but because it's a fatty type of bone marrow, one of the dominant types of cell that will be in there is an adipocyte. We also have some precursors to white blood cells in there as well, but given that this is an anatomy unit and not an immunology unit, we're going to skip past that just for a second. Now, you need to know that there's different types of bone marrow, because when you look at bone marrow, depending on the age of your patient, you might see predominantly red or predominantly yellow or a mix of red and yellow marrow. So you can see here in this infant under 1 year of age, the medullary cavity is predominantly filled with red marrow. Now, during childhood, what we have is a conversion from red to yellow, and that conversion begins centrally and it extends peripherally and axially. You can see by the time we've gone through to be an adolescent and then finally an adult, the vast majority of our bone marrow is yellow. So if you're, for example, looking at bone marrow on MR imaging, and this is a certain type of MR imaging, this is referred to as T1 weighted MR imaging. And don't worry too much about the details, but just know that there's different types of MR imaging that can be performed. Over here on the left in this 9-year-old, you can see that some aspects of the bone marrow in the medullary cavity of these vertebrae are bright, and that's going to be our yellow marrow. And you can see some aspects of the medullary cavity of these vertebrae are very dark, and you can see that anteriorly here. So this is going to be our red marrow. So we can see here in this 9-year-old, we've got predominantly red marrow, but we've started to get a conversion of that red marrow into yellow marrow. Whereas here in this 40-year-old, you can see that the vertebral bodies and their medullary cavities are predominantly bright. And this is because at 40 years of age, you've almost completely gone a conversion from red to yellow marrow. So that's why we see here on this MR imaging that yellow marrow appears bright, but red marrow appears darker. Now, we couldn't, of course, talk about bone without talking about the cells of the bone tissue. Osteocytes are really kind of retired bone cells. They were previously osteoblasts, and they got walled in by layers of mineralized matrix, and they hit an early retirement, and they just kind of pot around doing the gardening, and their role is bone maintenance. Osteoblasts can be found on the periosteum and the endosteum, and their role is in bone deposition. See, they secrete osteoid, and osteoid is defined as being unmineralized matrix. Now, what osteoblasts do, as well as secreting osteoid, is also mineralize that osteoid, and they do so by releasing an enzyme, and this enzyme is called alkaline phosphatase. Don't worry too much about the chemistry of alkaline phosphatase. However, suffice to say, one of the roles of alkaline phosphatase is to keep concentrations of calcium and phosphate high at the surface of the osteoblast. Now, what happens, and this is quite interesting with this alkaline phosphatase, is this is actually a marker, a serum marker for bone turnover. So in certain diseases whereby you might get accelerated rates of bone turnover, like Paget's disease, for example, you can find high alkaline phosphatase in the blood serum. But you also find high levels of alkaline phosphatase in growing bone as well. So it doesn't always indicate a disease state. So if you took the blood of, say, for example, an 8-year-old, you would find high levels of alkaline phosphatase as well. Osteoclasts. Osteoclasts are responsible for dissolving bone matrix, and they're responsible for bone resorption, so the breakdown of the bone matrix. And they do this by releasing protons. See, a lot of the minerals within the inorganic matrix of bone are acid soluble. So if you can release high levels of protons, then it decreases the pH surrounding the osteoclast, which is going to resorb bone. In addition to these three types of cells, we have the osteoprogenitor cells. These are found on the endosteum and the periosteum of bone, and they're precursors to osteoblasts.